For the med students, you know, there is no better time to be in healthcare than today. I got to be honest with you, I wish I was a medical student today, but those were 20 long years ago. There is no time in the history of medicine in our country where so much is changing and so rapidly. There's so much changing. Every day, something else is changing in medicine. And a lot of it has to do with things that are going on in Washington at a national level. But just to appreciate it, and now this is a comment for the faculty, you know, can you remember a time, especially the older faculty who have done this far longer than I have, can you remember a time where so many things are changing so exponentially fast, where the practice of medicine is simply fundamentally different from the time that you entered medicine?
1966.
That was a long time ago, where doctors just made decisions for the patient, right? Today, it's a whole different ballgame. It's very, very different. But some people look at me and say, that's why I hate medicine, because everything changes. I don't know what I signed up for. And every other day, I get 10 other emails about how something is changing, especially in the hospital environment. Well, I want you to think about it differently, especially the med students. Today, because of the change, it's possible that you all might just get it right. A lot of us who have been in healthcare long enough have gotten it wrong. And in no other sphere of medicine have we gotten it wrong than at the end of life. So, although things are changing rapidly and you might get disoriented, trust me, you might be able to navigate it just better than any of us did. But I'm going to speak to another hat that many of you wear today. The med students, the older folks in the room, you have probably had a grandparent, a mother, a father, a spouse who has had a serious illness, where decision-making at the end of life was not happening to you, but happening to your loved one. And so, as we go on our journey over the next 45 minutes or so, I really want you to think back to that time where you sat across from your loved one, where you sat across from that desk from that doctor who never asked your loved one what was important to them. How did they want to spend whatever time they had left? So that's where we're going to go. 3 seats up here, 4 seats, looking quite nice. If we could lower the lights so you could see the graphics a little bit better. I mean, I'm from Boston, but come on, I'm going to bite. When we ask most Americans where do they want to die, where do they tell us? Home. In that most prestigious scientific journal called Consumer Reports, over 90% of Americans want to die at home, surrounded by their loved ones, and focused on comfort. Did someone just turn the lights back on? But what are the facts? Where do most Americans die today? In hospitals. In fact, if you're over the age of 65, 2/3 of Americans will die in a hospital, in a nursing home, often tethered to a machine, and in a good deal of pain. That misalignment between the type of medical care people want and the type of medical care they end up getting in our healthcare system today is what I consider the most important problem in healthcare. Now, all of you have been reading about it every other day on the front page of the New York Times, on CNN, on MSNBC, on Fox. There's another story about care at the end of life. It's remarkable. No other time has this topic received so much attention. Unfortunately, the prism through which it is often portrayed is through the prism of cost. I'm not going to lie to you. End-of-life care in America is extremely costly. But you know, as a doc who practices in the trenches, I don't care. Our government gives 20% of the GDP to the Department of Defense. I say give more to healthcare. Why not? What I'm concerned about is that when Americans get care at the end of life that they simply never wanted, I'm concerned that we are delivering a lot of unwanted care. How is it possible that so many of us want to die at home, surrounded by our loved ones and focused on comfort, and yet most of us are dying in institutions just like this? Why? And for the medical students, you're going to hear a lot about this as being called a medical error. And I want everybody to think about this. When we talk about medical errors, almost all of us think about that surgeon who amputated on the wrong side of the body. We think about ICU checklists where the ICU doctor did not follow some checklist when inserting a central line. But shouldn't we be thinking about care delivered at the end of life as a medical error? When people end up getting things that they never wanted at the end of life, it's no different than your surgeon amputating the wrong side of the body. It's no different than infectious disease when you don't wash your hands in between patients. When you get things that you never signed up for at the end of life, it's a medical error, so let's call it for what it is. Why is it that so much unwanted care occurs in our healthcare system today? Well, I think it's because most of us, or I'll just say many of us, were never trained to have the conversation. I was never told to ask a patient, "Patient, what's important to you?" "Patient, how does your religious, spiritual, cultural beliefs impact what sort of medical care you want, especially when you have a serious illness?" In fact, I would argue I was probably trained not to ask the patient that specific question. I was told to be a technician. I was told to tell the risks and benefits of many of our interventions, while at the same time forgetting that I was talking to a person. But you know, conversations may not be enough. Today, we live in a visually literate society, and sometimes we need images to better inform patients about what are the questions that we as doctors, we as healthcare providers need to ask our patients, but patients also ought to know what are the questions they need to ask us. Look, I've been practicing in godless Harvard for about a decade, and I have never heard a clinician ever ask a patient, what are your spiritual and religious beliefs? How does that impact the care that you deliver at the end of life? My question to you is, how could you possibly answer a question about end-of-life care unless you raise those type of questions? But before we get too serious, it is end-of-life care. I'm a kid from Brooklyn, so I want to talk about stories. So I'm going to introduce a story. Here's Professor Helen Thompson. Boy, that is annoying static. Oof. Helen Thompson was one of this country's foremost literary critics on the poetry of Walt Whitman. How many of you are familiar with the poetry of Walt Whitman by show of hands? About half of you. Most of the older folks, not so much the students. Well, by the way, when I asked my med students that, not a single hand went up. So disheartening. Well, I was born and bred in Brooklyn, New York, where Walt Whitman spent the first half of his life. So every other street corner had a Whitman elementary school, and all the pupils were forced to memorize the opening lines of Whitman's magnum opus, The Leaves of Grass. So Professor Thompson and I both hit it off because we could both recite those lines. I celebrate myself and sing myself, and what I assume you shall assume, for every atom belonging to me as good belongs to you. Now, you may be asking yourself why I came halfway across the country to tell you about Helen Thompson or the poetry of Walt Whitman. Well, what I haven't told you is that Helen Thompson was my patient just a few years ago. What I haven't told you is that Helen Thompson was an elderly female with widely metastatic cancer being admitted to my hospital. What I haven't told you is that Helen Thompson was dying. And so on that day, I did my history, I did my physical, and then I got to that part in the H&P that all of us get a little bit uncomfortable with. And that's when the words of Whitman metamorphosed into other words. Words like goals of care, CPR, breathing machines, comfort care. So I looked at the professor and I said, "Professor, you have seen scores of doctors before ever laying eyes on me. You've seen oncologists, pulmonologists, intensivists, primary care doctor. Surely someone has started the conversation with you. Surely someone has asked you questions like, what's important to you? What are your religious beliefs and how does that impact what the heck we're going to do in the hospital?" And she looked at me with that blank stare that so often our patients give us. And so I started my own conversation with her. I said, "Professor, I think it's really important that we have a forest from the trees perspective. I think I need to know a lot more about what you believe. I think it's also important that we understand what are the risks, what are the benefits of all these things that I could potentially offer you, but I need to know where you are on your journey with this illness." And that's when she continued to give me that blank stare. And that's when I naively asked her, I said, "Professor, would you mind taking a walk with me to the intensive care unit so I can actually show you some of these things?" Of course she obliged. We didn't walk to the ICU. I put her in a wheelchair, rolled her down to the intensive care unit, got to show her a vent, got to show her a patient on a vent. There were a couple of residents in the ICU. One was inserting a central line, another one was performing an LP. And what the professor was able to do was to get a sense of the place, to hear the beeps and buzzes, see the colorful monitors, feel the rhythm of the intensive care unit. Now, as fate would have it, I obviously didn't plan on this, but there was a code blue in the ICU, and that's when I immediately whisked the professor out of the intensive care unit, but not before she caught a few glimpses of CPR. When we went back to her room, she looked at me and she said, "Words, words, words. Angelo, I understood every single word that you said before. Breathing machines, CPR, hospice care. I am, after all, a professor of English. But I had no idea that's what you were talking about. Doesn't look like that on television." And that's when it occurred to me, at a young professional age, that so often in healthcare, we as doctors, as healthcare providers, try to start these conversations with patients, but most of the time, our patients are thinking about Grey's Anatomy and ER, where everybody survives CPR, where the miracle cure for your cancer is right around the corner, and where everybody looks like George Clooney on a vent. Oh, come on, that was a funny joke. Well, what I started doing, and got a lot of trouble for it, I started taking all my patients and their loved ones on their own personal tour of our hospital. I used to take them through the intensive care unit. I used to take them to our dialysis unit. And what every individual told me was that this was the most powerful and empowering experience that they had ever had, that they couldn't imagine making a decision about care at the end of life without this tour. Now, the nurses, who are the wisest people in the healthcare system, for the med students, and if there are any residents, always listen to your nurse. You're attending, try to listen to him or her, but the nurse, always listen. The nurses loved what I was doing because they saw the educational value, and they understood that this tour prompted questions that these patients had never been asked. But at the same time, they put quickly an end to my tour business because they knew I was breaking patient confidentiality. And so here's the conundrum that I was left with. How could I recreate this powerful and empowering experience for patients and families to get to know the questions that they need to ask and to understand the interventions that are available to them? And that's when a group of us came up with an idea: create short films to better inform patients and their families. Just think about it. Today, doctor is still king or queen. We are going to talk about what I want to talk about. But suppose patients who don't know the questions to ask, who don't know that they have a right to talk about their religion or about what's important to them or what's on their mind. Patients don't realize that, especially our older patients who still think God means doctor. What if people were actually empowered to know the questions that they need to ask, to reflect on? What if patients actually understood their options? What would we have? We'd have a very different dynamic in that patient-doctor relationship where the patient and their loved ones are on equal footing with us. And that's what we do. Now, it's not just me, it's a group of 100 of us from 10 academic medical centers around the country. And the interesting thing that we do, at least I think it's interesting, is we not only create these short videos, but we actually study them to see what's possible when the patient actually knows that they have the right to ask questions of the doctor. What if patients and families actually understood what their options for medical care are? And so what I'm going to do is present 2 of our studies that we have done to see you all can imagine what's possible if people in the Twin Cities actually understood all the right questions to ask you when they come to see you with a serious illness. What kind of healthcare system would we have? What if we not only stopped having these conversations in the healthcare system, but can we foresee a time where people, before they're patients, they're people, they actually start conversations like this outside of the healthcare system? I often tell my patients, look, I don't want to start this conversation with you in the hospital. I think you need to go to your pastor and go to church and start this conversation. I think you should probably do this with your family this Thanksgiving when you see them. Why is it that we as doctors often limit these questions to what happens after patients enter the hospital or the healthcare system? These are questions that don't require an MD to reflect on. So the first study that I'll talk about is in one of our very first studies where we looked at patients with advanced cancer. These were patients all with a serious illness. What would happen if patients saw a video that told them, these are the questions that you should be asking yourself, and these are your options for medical care if you have an advanced serious illness? And these patients indeed had a serious illness. Then I'll talk about a study that we did looking at the inpatient setting in regards to CPR, and then I'll talk about the future of this work and ask you to think about, is it possible that the conversation becomes the new normal right here? So that's where we're going. I'll be sure to leave about 10 minutes for Q&A, and feel free if you have a really urgent question. When I was in elementary school, I used to go, ooh, ooh, ooh. So if you really have a burning question, go ahead, just raise your hand and I'll try to answer it. For our very first study, we looked at 50 patients, all with advanced cancer. These were patients that were seen at my hospital. These patients all had less than 6 months to live. And what we did is we split the group. We randomized them into 2 groups. Half of the patients had a verbal discussion about what was important to them and what their options were for medical care. The other half of patients had the same discussion, but then saw a video, and I'll show you a video as well. Now, the 3 options that all patients in America have are these 3: life-prolonging care, limited care, and comfort care. And this is really for the med students. The older folks, the faculty know this. But with life-prolonging care, the goal is to prolong life. It would include anything available in a modern-day hospital: CPR, the ICU. Limited care, the goal is essentially hospitalization without the ICU. And the third category is comfort care. Here, it's essentially symptom relief. Now, those are the three options everybody has in this state. But for those who got to see the video, they got to see visual images of each of those categories of care. Now, I want you to imagine a short video, 5 minutes long, that runs through what are the questions a patient should be asking? What are their options? And before I actually show you one of the videos, and this one it's on YouTube, so you can use it with your patients. What I find is a lot of medical students use it to train themselves because you don't get trained in medical school to talk about this sort of stuff. That was a joke. Man, no coffee? But the question that I have for you is, remember your loved one? Remember your grandparent with advanced cancer? Remember sitting across the table from that doctor who never asked them any questions, but just told them the type of care that they were going to get? Just imagine a time where we actually have discussions like this outside of the healthcare system, with our families, with our pastors, and then imagine what sort of discussions we would have once our loved ones actually knew what questions to ask. What type of medical care system would we have? A question for the medical students. Raise your hands again. I want you to be honest. Are your teachers, faculty members, attendings, when they have these discussions with patients with a serious illness, are they asking questions like that? Are they telling them questions like, what's a good day for you? What are your spiritual and religious beliefs? Are they speaking at a literacy level that a patient for whom English is a second language can actually understand? Are they speaking at a pace that a sick patient can actually hear what the heck you're saying? Almost all of you are shaking your heads. Look, I'm going to be honest. I think and breathe this stuff, and I don't even have conversations like that. I often forget to take a spiritual history. I often forget to remind patients about what their options are. I'm a hospitalist. I have 22 patients. I have 12 minutes maybe with each patient. I'm rushing. I just gave a talk to the medical students and I ran to a family meeting and I caught myself saying ventricular fibrillation, doing a family meeting, a family for whom English was not their first language. And I had to catch myself. I was like, I can't believe I just said that. Well, what a great idea if we have a tool so that patients and families know what the questions are that they can ask us. It flips the dynamic. It gives some of the power back to patients. All of us talk about patient-centered care. Baloney, it's doctor-centered care. When I walk into that patient's room, it's all about me because what transpires is directed with what I ask the patient. Think about that. Okay, remember those 50 patients in our study? What do you think people wanted? In yellow, we have life-prolonging care, and blue is limited care, and green is comfort care. Our second-year med students, raise your hands. I know that. Take a guess. What do you think people who just had a conversation, what do you think they wanted? These were all seriously ill patients. What do you think they wanted at 100%? Life-prolonging care, limited care, comfort care. So if you added the first two, what percentage out of 100? Oh my goodness, maybe that's reflective. What was that? 75. So 26% wanted life-prolonging care, 52% wanted limited care, and 22% wanted comfort care, which is close to 75. Good for you. I'll be honest, I admit these patients to the hospital all the time. I wasn't surprised by this distribution. About a quarter of my patients want life-prolonging interventions, a quarter want to focus on comfort, and half of people still somewhere in between. What about the group that had that conversation and saw that video and actually got to understand what are the questions that are important to me, the patient, not what are the questions that are important to the doctor. Anybody want to take a guess? Call out some numbers. 50 what? 50-50. Any other thoughts? Sir, with the red t-shirt, what do you think? Distribution out of 100, just to guess, 100%?
I'm trying to remember the Atlantic Monthly.
Oh, bad. Oh, man. It's on your honor that you didn't already see the study. By the way, all these results are public information. They're peer-reviewed journals. They're all freely accessible. Now, when patients actually get to ask us those questions, when they actually understand their options, not a single one, when they have an advanced terminal serious illness, wants life-prolonging care. Most of them want to focus on comfort, which is what the survey from Consumer Reports suggests. Is it possible that when patients know the questions that they need to ask us when they navigate the healthcare system, they do a better job at getting the care that they want? Yes. Think about it. Now, I'm not showing you all the variables, but people who saw the video had much more information. We quizzed them. They were much more knowledgeable about the questions they needed to ask and about their options. And they were more certain about their decisions. Things that are all good from the patient's perspective. Look, I'm going to be honest with you all. Today in America, we're trying to start these conversations. But most of us are failing. And what's happened? 2/3 of people are still dying in our hospitals, often tethered to machines and in a good deal of discomfort. But what's possible? Can we imagine a time when patients are in the driver's seats, when patients know the questions that are important to them? Then what do we see? Decisions that are consistent with their wishes. A very different state of affairs. Look, I would say back in Brooklyn, if you did anything upon my body that it was against my wishes, it was called assault and battery. In healthcare, it's called the standard of care. I'm going to keep questions towards the end just because we started late. The next study that we did was about CPR. And the reason why we did this study is because CPR is the most common decision point in American healthcare. Every patient that enters the hospital must necessarily answer this question. But the fact is, most of us simply don't ask the patient this question. And they get the default, which is, do everything. And so we conducted this study, which got a good deal of press because the results made us look pretty bad. And by us, I mean man's greatest hospital, which is also known as Massachusetts General Hospital. Oh, so you laughed at that, making fun of myself, which is my hospital. No, it's not man's greatest hospital. In fact, a lot of the work that I do makes us look horrible. And in fact, I'm shocked that my CEO actually lets me do this. But you know, I'm proud to be part of a hospital that is willing to air its dirty laundry so that all of us just might get it right. So what we did is we took 150 patients, all with a serious terminal illness, admitted to our hospital. These were patients with advanced cancer, advanced liver disease, kidney disease, advanced heart failure. And what we did this time is we split the group, randomized them into two groups. Half of the patients just got usual care, whatever's delivered at MGH. The other half got usual care and then saw a short video that told patients, these are the sort of questions you need to think about, and this is what CPR looks like. Now, I'm not going to show you that video just for the sake of time, but it's a shorter version of the YouTube video that I showed earlier. And by the way, I'll share the link with you to the YouTube video at the end, so you're kind of stuck waiting until the end. You know, I know most of you came for the pizza. So now let's go to the 3rd or 4th year medical students. What do you think people wanted with usual care? These are all people with an advanced serious terminal illness. What do you think they wanted? Red is yes, I want CPR, and blue is no. Where are the third and fourth year med students? Raise your hand. All right, back to the first and second years. So what do you think? %75%. And my good friend, who was nice enough to email some of her colleagues, what do you think? 64% in red wanted CPR attempted. The remainder did not. What about the group that saw a video that told them, you have the right to ask this question of whether or not you want this, and this is what's important for you to know about it? What do you think the distribution of preferences were? Jocelyn, I know you're a lonely undergraduate here. There's only 3 of you. 75 no. And our School of Public Health folks? So 33% wanted CPR attempted. The remainder did not. And just for those of you who aren't clinicians and the med students who are still early in their career, why is that really important? Because the fact is, most of us in America simply don't have these conversations when you come to the hospital. So you have advanced cancer, you're coming into my ER, it's 4th-line chemotherapy, it's not working, you're vomiting. No one has had this conversation. The ER attending evaluates you, sees that you're vomiting, and he's saying to himself, gosh, this is a real sick patient. I'm not going to start having a conversation with them. I'll pass it off to the night hospitalist. Now the night hospitalist sees the patient. She says, oh my gosh, I have 2 other patients that I have to see in the ER in the middle of the night. I'm not going to talk to this patient. I'm going to pass it off to the morning hospitalist. Now it's 7 o'clock in the morning. That morning hospitalist, she sees that she's getting a really sick patient. She has 21 other patients. She's saying to herself, I'm going to run and see all 21 of my other patients, and then I'm going to see this really sick patient. Now it's 3 in the afternoon. No one has bothered to ask the patient what's important to you. The poor nurse comes in. He checks a pulse. It's 30. A code is called. The patient is coded, intubated, central lined, brought to the ICU, an intensivist, an oncologist, 30,000 other consultants, and a distraught family now have to struggle with that question, what's important to you? And simply because no one took the time to start the process early. What if patients already knew the questions that they needed to ask us? So in this study, we actually asked people about breathing machines, and in usual care, this is what people told us, about 50-50. And for the group that saw the video, 17%. How many averted ICU admissions would we have? How many patients who have been intubated who never wanted it do you deliver care to? Care in this hospital. But you know, I really had it out for my own hospital. I wanted to know how many people actually documented something in the electronic medical record. How many people actually had something documented in usual care about what they wanted? Take a guess. These were all seriously ill patients. 2%. I should mention that these were patients we followed over a year, so they either died or came back to our hospital. So over the course of that year, what do you think for usual care? Anybody? 43%. What about the video arm? Ooh, 81%. Who said 80? What do you think happened?
I guess that for a number of patients, prevent them from being sent to the ICU.
Right, so the patients were raising the questions with the doctors. Patient would see the video, they knew the questions that they needed to ask, and they told the doctor, sit down, we're going to talk about this, not just my medicines. But I went one step further. Our group actually looked at how many people got coded or intubated, nonetheless, the people who never wanted this, over the course of a year or at death. Usual care. What do you think? Throw out some numbers. Faculty.
1 in 3.
Now we're talking. 22%. What about the video arm? 4%. And those 4% were patients who had a temporary reversal of their code status for a simple surgical procedure and then reverted back to their original preference never to be coded. And although we defined the outcome variable the way we did, that's why we included 4%. But I got to be honest, that's probably the right thing to have done for those 4%. So I'm actually going to go a little bit faster, and because there's so much to talk about. But you know, I think it's important that as providers, we ask our patients, what do they think about when they're educated about the questions they need to ask, and have a video that goes over these questions before they ever lay eyes on us. 90% find that helpful, 93% are comfortable with these questions, and 97% would recommend the process for their loved ones. When did 97% of our patients recommend anything other than staying away from us? Think about it. But you know, data is data, and words and stories are far more powerful. This is what patients tell us.
You explained what the disease is, and I heard you. But I didn't understand you. After the video, I now do.
You know truly what is happening. Reality is not left to your imagination. You see it. Actually, seeing the disease is better than verbalizing it. I had a very different idea of what the disease and interventions were. This video was totally different.
When a doctor's talking with me about a disease or something like that, hey, I have ideas in my mind about it, but if you really see, you know, a real person who actually has it, then you really get it.
Yes, I have my own idea of what this disease was. After seeing it, it was very different. You get to see the real people, real patient, real disease with the disease. Video makes it concrete and easy to connect to. Video is much better than talking. People don't understand what you are saying. I am a picture person. I am a better learner visually.
And I think all of us hear that from our patients. I'm a visual learner. I learn through concrete images. So what we have done is we've actually partnered with over 200 places around the country where this becomes the standard of care, where patients are no longer in the dark, where they actually know the questions they need to ask us, and when it is truly a patient-centered model. But one of our largest projects is where an entire state has prioritized having the conversation, and that is the state of Hawaii, where 15 hospitals, 50 SNFs, 10 hospices, 600 physicians, 1.4 million residents have prioritized having the conversation. And it's not in the hospitals, it's actually starting at church. And then when they come to the hospital, they've already started the conversation with the doctor because they've already started the conversation with their family and their pastor. What is possible? But let's just be clear. You need to meet people where they're at, and a video of me telling a patient, you know, what are your spiritual religious beliefs in Hawaii ain't gonna cut it. I don't look Hawaiian. So we refilmed a lot of our films using the chair of medicine
I'd like to talk to you
from the
about
University of
decisions
Hawaii.
you might have to make.
And although my group created a Spanish version of the video, for those of you who know Hawaii, there aren't many Latinos in Hawaii, but there sure are a lot of Chinese Americans. So we created videos in Cantonese and Mandarin. But why stop there? Hawaii is one of the most diverse states in the Union. Filipino languages, Tagalog and Ilocano, Japanese, Korean, Vietnamese. But for us, because we are most interested in minority populations who bear the brunt of the inequities in our healthcare system, the minority populations in Hawaii are the Samoan populations, and we created the first ever Samoan video and Marshallese or Chucky's video. And just that you could imagine what's possible if we as a community actually focus on having the conversation. There's been a decrease in hospital deaths by 30%, an increase in post completions by 42%, and an increase in referrals to hospice by 25%. What's possible if patients take back our healthcare system and they're in the driver's seat? So it's 1:04, and I'd like to end with a story because I think it's important, especially for the med students, that we remember that at the end of the day, that person that we are caring for is not just a patient, it's someone loved one, and someday will be you and will be me. Death is not optional, not even in Boston. Taras Shevchenko was a living part of American history. As I later found out, Taras was an ethnic Ukrainian who had emigrated to the United States from the Soviet Union. He was one of the lucky few who escaped the chaos before World War II began. Taras wanted to start over, to rewrite the opening chapters of his life. At 18, he found a new home. Oh my goodness. At 18, he found a new home in a Ukrainian enclave in one of the mining towns of Appalachia and quickly found labor in the coal mines. For years, he led a life of unremitting physical toil, working 12-hour shifts 6 days a week. Unfortunately for Taras, a lot of the detritus from smashing coal dug its way deep into the lining of his lungs. It would also plant the creeping cancer that would devastate him decades later. This once hulking mine worker had dwindled to a mere whisper of his former muscular self. This bedbound 78-year-old with inoperable lung cancer was admitted to my medical service during my first year of residency training. Slowly suffocating to death, he experienced both transient moments of hallucinatory joy and unconscious, yet peaceful somnolence on the oncology ward. Taras was too confused to have a lucid conversation and lacked any family members to guide his decision-making, so his medical plan was the default approach for all patients: do everything. Despite my efforts to come up with a plan, I knew that Taras had a plan of its own. I knew his cancer had a plan of its own. Doctors can fool themselves into thinking that they are in charge, even when disease and pathology are in the driver's seat. Frequently, we are only along for the ride. Taras was dying. I knew it and the nurses knew it. But as far as the medical team was concerned, if his heart stopped beating, we were going to perform CPR. Exhausted from a long day, I paged the overnight resident to meet me in the cafeteria to review my list of patients before I signed out. The overnight doctor was a senior resident named Edward, and I was glad a senior resident was on call that night. Taras was going to need him. He's a Ukrainian gentleman who worked in the coal mines of Appalachia. About 8 months ago, he began having a cough, saw his primary care doctor, ordered a chest x-ray. "Stop right there," Edward said. "Start again. Start with initials, and then in one line, give me the pertinent info. Less is more. I have 30 other patients to cover tonight." When a resident is responsible for 30 patients at night, too many personal details can muddle one's thinking. T.S. is a 78-year-old male patient with metastatic lung cancer, I said. He's really sick. Modern medicine can be dehumanizing, and the first step in that process is to remove all the individualized details, to obliterate personhood, and replace it with patienthood. Code blue, code blue. Edward and I sprinted towards the oncology ward. We finally arrived at Taras' room. I was always taught to hope for the best, but prepare for the worst. But it's not always clear how to define the worst. The nurses who had called the code blue had already started CPR. I clumsily jammed my hands into a pair of rubber gloves and joined the ritual, which is far more brutal and demanding than what is portrayed on television. Edward stood at the foot of the bed. I searched for a pulse on Taras' neck. Any fat had melted away long ago, and all I could feel was cartilage and windpipe. It's an eerie feeling sliding bloody-gloved fingers along the skin, searching for signs of life. Shockingly, I found a pulse. Taras had a normal rhythm. The team had saved the patient, and now it was time to transfer him to the ICU. Edward and I bundled Taras and his machines onto a gurney and squeezed into the narrow elevator. I kept my hand on his carotid, making sure he had a pulse, until I realized he no longer had one. Taras was almost dead. There was no space alongside the gurney, so I jumped on, straddled him, and started performing CPR. In all likelihood, the cancer had spread to the thin sac surrounding his heart. allowing blood and fluid to seep in and surround the vigorously pumping heart muscle. To get the heart beating again, a doctor needed to stick a large needle into his chest. We needed to move fast. "Do you feel comfortable doing this?" Edward said. I told him that I had performed the procedure on a cadaver in an anatomy class, but had only seen one on a patient. "See one, do one, teach one. Here's your chance on a warm body," he rejoined. I descended from the gurney. Edward handed me a large needle. My hands were trembling, not surprisingly, since you don't know how deep to slide the needle into the body. Every body is different. Some are fatter than others, and others more muscular than fat. I pierced Taras' skin just below the sternum. No luck. I tried again and again and again. By the fourth time, I gave up. Residents are usually allowed 3 strikes before being asked to stop. Edward gave me a 4th, since this was my patient. I probably should have stopped after the 3rd. Taras' ribcage had become a pincushion from all my attempts. As soon as we entered the ICU team used an ultrasound and removed the fluid surrounding his heart. Taras had a beating heart again. Taras' care was now being managed by the ICU team, so Edward and I headed back to the cafeteria to grab some coffee. After every code blue, the team is expected to review what transpired. It's a ritualized moment to grapple with the trauma surrounding a full-on code. Debriefings are always difficult, as each of us dials down the rapid pace of a code blue to digest the events that have just transpired. We sat quietly for a few minutes. "We just completed a by-the-book code, but I wonder if we did the right thing," I said, needing to tell Edward what was on my mind. Perhaps it was because I was a young doctor and had not yet been numbed to the brutal experience of caring for hundreds of patients. "We did exactly what we were taught to do. Everything was by the book. Look, this is the system. We have a job to do." But we both knew something was not right. "I can't believe we just did all that to a man who's got 1 foot in the grave," I pushed, not mincing my words. "Would he have wanted any of this? Would you have wanted any of this? Would you do this to your dad? Something is wrong with a system that puts terminal cancer patients through torture." Edward put a hand on my shoulder. "It's going to be all right. You're still new at this. You'll get used to it. Get some sleep. Page me in the morning." Get used to this? Is someone supposed to get used to this? Over the next 2 days, Edward and I visited Taras every few hours in the ICU. He was no longer our patient, but we could not let go of him either. By the following morning, he had a tube or catheter in almost every part of his body, a grand total of 8 plastic intrusions. Taras was fixed. Doctors like to tackle problems and fix them, and it's truly amazing what modern medicine has achieved in a relatively brief span of time. The tougher issue, however, is when to recognize that the small fixes do not change the larger picture, to recognize that fixing specific problems may not fix the whole patient. This is medicine's version of not seeing the forest for the trees. Doctors always search for the next fix, but we need to know when to use or not to use our growing toolkit of fixes. Taras' heart had stopped 3 more times, and miraculously, the ICU team had brought him back each time. But not surprisingly, a patient in the late stages of terminal cancer succumbed to his disease. Whatever the next new fix is, nature eventually takes her inexorable course. Taras died 48 hours after that code blue. Americans receive some of the best health care money can buy. They also experience some of the worst deaths in the developed world. The primary reason we experience such horrible deaths is doctors' failure to openly discuss care for patients with a serious illness. Taras Skripchenko died 15 years ago. I have since witnessed hundreds of deaths, but his, which I experienced during the formative years of medical residency, haunted me for the first decade of my life as a young physician. so too did that conversation as I tried to make sense of the drama that had just unfolded in front of me. Today, I'm a full-fledged physician, a senior doctor and teacher of others. But I still think about that as each time I meet a new patient. A new beginning, a clean slate, but also a potential TS. Thank you very much.